Good afternoon, everyone. I want to welcome you all and thank you so much for taking the time to join us for our Mentoring Youth Impacted by Opioids mentor training. If we have not met before, my name is Julie Redkay and I'm the Senior Director of Federal Grants here at Big Brothers Big Sisters of America. Today for our session, our goal will be to provide you with key information to understand the important role that you as mentors can play in substance abuse prevention with your littles. Our experts are going to address the state of the union for the opioid crisis in America, give you a scientific overview, what's happening with opioid addiction, and provide you for the resources for how you can help your littles with substance abuse prevention. A few housekeeping notes. Please note that we are going to be recording today's session to ensure that the mentors who were not able to join us today will have the opportunity to attend virtually. If you have any questions during today's presentations for any of our experts, you can type those over into the chat box on your right-hand side of the screen. I want to say that we are thrilled to partner with the DEA Educational Foundation, as well as the experts who were able to come today on our session. The DEA Educational Foundation, they model their organization to fight drug abuse through education primarily. They proudly sponsor Operation Prevention, which is a joint endeavor between the DEA and Discovery Education to combat a growing epidemic of the prescription opioid misuse and heroin use nationwide. We are so fortunate to have with us today Meredith Liepelt with us, who serves as the PR evaluation and special projects consultant for the DEA Educational Foundation youth programs. She has worked with the DEA Educational Foundation for over 10 years with a focus on the National Dance Program specifically. She manages PR, evaluation, other special projects for the National Flagship Youth Program. Her degree in communication and a minor in theater from Lynchburg College has helped to pave the way for a very fulfilling and interesting career. She's the founder of a coaching and consulting company in Columbus, Ohio. And as a parent herself and an active member of her community, she's really invested her talents in helping the foundation with its important message as she sees every day the impacts of drugs in America. Thank you so much for being here today, Meredith.
Julie, thank you so much for that introduction. I'm thrilled to be here today. And thank you to everyone who's here today, all you mentors today, who are here today for this really important opioid awareness seminar. So this situation out there has affected probably everyone on this call in either directly or indirectly. And so whether you're a mentor, a parent, a caregiver, a child, a business professional, we've all been impacted in some way. So thank you for being here. This seminar was created so that you as mentors can hear from a variety of presenters about this topic so that you can have further support in your own roles as a mentor in the community. So in terms of what to expect over the next hour, we're going to hear from two presenters. I will ask for your input or your questions a couple of times throughout this hour via the chat box. So please don't be shy. We want this to be interactive and fun. I will let you know when to do that specifically. So please participate. It's easy and we want to hear from you. In fact, let's start that right now. I'd love to hear in the chat box, if you could just put in your city and state where you are calling in from, so we can just see, I know that we've got mentors from across the country. So just in the chat box, if you don't mind, just put in your city, your state. If you want to add something fun, like your favorite movie or something like this, that would be great. Oh my gosh, this is fantastic. Indiana, Tennessee, Utah, Nevada, New Jersey, Washington, D.C., California, from everywhere. We are from all over the place. So thank you all for joining us. Great work going on with you mentors across the United States. Thank you for being here. So again, today our aim is to give you information that you can use and put into practice and to hear from you as well. We will have a dedicated Q&A time. So if you have questions as you're listening to our presenters, jot them down. Do not lose those questions because we want to be able to answer as many questions as you have. And I'll tell you when to do that. So again, I just want to say that your work as mentors is so important and thank you for all that you do. I'd like to kick this off by introducing our first presenter, Sean Ferns. Sean has served as the Chief of Community Outreach and Prevention Support for DEA since 2015. This position includes management of the DEA Museum, as well as the DEA Community Outreach and Prevention Support Section. In this capacity, Sean is responsible for guiding a diverse and creative staff to develop and implement strategic national partnerships with other organizations which help educate the public on the current drug threats facing the country, support the DEA field divisions, communicate key administration drug prevention messages, and reduce the demand for those drugs, including implementing the DEA's Operation Engage. So Sean, I'd like to turn the floor over to you.
Meredith, thank you very much. I appreciate the time. Let me start by saluting the Boys and Girls Clubs, Big Brothers and Big Sisters, and every single mentor that are joining from across the country for this session, whether you're watching live from California or Ohio or Nevada, or you're going to be watching this pre-recorded later. We're going to give you a quick state of the nation when it comes to the drug issue, because truly for you to be informed and educated is so critically important as you talk to your littles, so that you can have informed discussions and be knowledgeable. So let's talk about some of the emerging drug threats. There are some significant issues that are facing the country right now, and it's absolutely critical that you guys are aware of those. And for some reason, my slides are not advancing. Let me see what we're doing here. There we go. Okay, so what we're going to do is we're going to talk about things from the National Drug Threat Assessment. This is developed every year by the DEA, by our men and women of the Drug Enforcement Administration, working with hundreds of state and local law enforcement agents across the country, looking at the assessment of these major drug issues. There are 6 top drug threats that we need to talk about. Obviously, opioids is the most critical of those. And where do these drugs come from? What are the sources of supply? And quite frankly, Mexican transnational criminal organizations are the greatest drug trafficking threat to the United States. They control most of the US drug market. Illicit fentanyl is the primary item responsible for fueling the ongoing opioid crisis. It is an epidemic in this country. It has gotten worse. We're going to talk about more about that as the session goes on. Methamphetamine continues to be readily available throughout the United States. If you thought that it went away when the Breaking Bad show ended on television, sadly, it has not. Cocaine has remained available throughout the United States, and that availability is steady. So it's not just opioids and depressants, but also stimulants, methamphetamine, and cocaine. Prescription drug diversion, that is the diversion of licit drugs into illicit use, continues to go down. That is actually a really good thing, that prescription drug misuse rather, has been decreasing. And then finally, what has COVID-19 done to the situation? It actually had posed challenges to drug trafficking organizations, making it harder for them to operate. And so what has continued to allow them to operate? So let's dive in a little bit. First thing is that bullet about transnational criminal organizations. You may remember them as the word cartel, even more sophisticated than drug cartels. There are a number of them. The first are the Mexican transnational criminal groups. They dominate the wholesale importation and distribution of every major drug. They may have started 30, 40 years ago with one particular drug. They have expanded. Colombian transnational criminal groups based out of Colombia primarily are focused on cocaine, and they are partnering with Mexican groups in order to transship their products from South America into the United States. There are now Dominican transnational criminal organizations. These are mid-level distribution networks, predominantly focused in the northeast of the United States, and they are mostly self-sufficient. They don't rely on other criminal organizations to operate. And then perhaps the most important issue on a local level, and that's domestic gangs. These gangs are opportunistic. They do not hold specific allegiances. They will shift at the drop of a hat, and they are associated with violent crime and the street level distribution and sales of illegal drugs. So let's talk a little bit about opioids. That was that second item that I mentioned as we began. The overdose death rate has climbed. I'm sure you have seen the news in the last couple of weeks that we passed a very grim milestone. America lost over 100,000 people to a drug overdose for the period of May of 2020 to April of 2021. That is the worst it has ever been. That is actually an increase of 29% over the same period a year before. Obviously, COVID has had a lot to do with that. 75% of overdose deaths involve opioids, and then 64% involve synthetic opioids like fentanyl. So to put that 100,000 number into context, that's 275 individuals every day. So fentanyl, the other F word, if you will, illicit opioids and heroin. Fentanyl is an illicit, we're talking about illicitly manufactured fentanyl, not the fentanyl that you get a prescription for chronic pain with the patch or lollipop. The fentanyl market is increasingly supplied by Mexican cartels. Fentanyl is the primary driver behind drug overdose deaths. Heroin and fentanyl markets are intertwined. It used to be that heroin was its own product smuggled and fentanyl was its own separate product. And the transnational groups have in fact merged it together. You will find fentanyl laced in with heroin, with cocaine, with methamphetamine, with marijuana, any of the major drugs of abuse. As I said, heroin adulterated with fentanyl. Seizures at our southwest border are increasing. Fentanyl-laced counterfeit pills are widely available. You say, well, wait a minute, that's a pill should be written by a doctor and filled by a pharmacist. What we're talking about are illicit counterfeit pills. They're made to look like prescription pills, like oxycodone, hydrocodone, alprazolam, stimulants like amphetamines. But the trick here is that these are made with small quantities of fentanyl or methamphetamine. You say, okay, what is it about fentanyl that is so horribly dangerous? And I don't want to cross into the science discussion, but I'm gonna do a little show and tell here this morning. This is a sweetener packet. It could be sweet and low, equal, whatever it could be. This is 2 grams of powder, 2 grams, 2,000 milligrams in this container. A deadly dose of fentanyl is 2 milligrams. So this quantity of powder, were it to be fentanyl, could kill 1,000 people. Just here, just that quantity right there. That's how bad we're talking about. The drug traffickers are making fake pills in clandestine laboratories south of the border to exploit the crisis that has been blooming for many years on opioids and the prescription drug issue. Even if the user doesn't know that that's not an actual prescription pill, there's no way to tell inside that pill how much fentanyl is produced. And if users are actually thinking that it's a prescription pill that they got from a neighbor or a family member, that's even more dangerous. Here's an example of a legitimate pharmaceutical manufacturing process, a good, clean laboratory with solid science being used to produce pharmaceutical products that are written by a doctor and filled by a pharmacist. Here is a clandestine fentanyl pill manufacturing operation down south of the US border. Again, nasty, dirty chemicals, gross conditions, unsound science, and who knows what's really getting in. Can you tell the difference? On the left-hand side of your screen is an authentic Xanax pill, and on the right is a counterfeit pill. Very, very, very realistic. An authentic Adderall on the top left versus a counterfeit Adderall on the top right. Again, to the average eye, you might not be able to really know the difference. How about the image below that, the 30 milligram oxycodone tablet? Which one of those do you think is authentic? Which one do we think is authentic? In this case, the authentic oxycodone is the pill on the left, and it's the counterfeit pill on the right. The authentic on the top, 30 milligram oxycodone, the counterfeit below it. Very difficult to determine the difference. Okay, let's talk about some of the other major drug threats that it's important to be knowledgeable about, and that's methamphetamine. Methamphetamine seizures are increasing around the United States. Mexican-based transnational criminal groups are the primary producers, and the number of labs here in the United States has been decreasing significantly, which that's a good thing. that it's not a domestic product like it used to be. However, deaths involving methamphetamine have been climbing back up again. They had really dropped down after the early 2000s, and yet they're going back up again. Let's talk about cocaine for a minute. It is readily available again across the United States. Cocaine overdose deaths are increasing. Nationwide seizures of cocaine are increasing, and cocaine production has reached record highs down in South America. Here's an interesting chart. If you look at this, this shows Colombian cocaine production for the last decade, from 2010 on the left to 2020 on the right. And as you see those green vertical bars going up, you can see that cocaine production has climbed in the last 10 years. The black line shows eradication efforts in Colombia. Eradication of cocaine had dropped dramatically by the Colombian government. So is it any wonder that production of cocaine would follow? Marijuana. Marijuana is the most commonly used illicit drug in the United States. It is readily available throughout the nation. It can be grown on public lands to the detriment of the local environment and the water supply. And of course, what's also confusing is how the national legal landscape is constantly evolving, which can be confusing. Mexico is the primary source for foreign marijuana, and now Cuban drug traffickers have established a presence in Colorado in an effort to take advantage of that legal local market to their benefit. Lastly, controlled prescription drugs. They are available in illicit markets that they remain high. It is declining, but it remains high. Abuse levels did go back up last year because of COVID. It is the second most abused illicit substance after marijuana. And hydrocodone are the most commonly misused pain relievers in the United States. And of course, the sad reality is that the majority of pain reliever abusers obtain their prescription drugs from a friend or a relative, which makes controlling your pills in your home medicine cabinet so incredibly important, and an important message to send to young people to not misuse pills that are available at home. You can read a lot more about this. I've just touched these highlights in this quick webinar that we have today. Please visit DEA.gov and you'll be able to see more. And I'll be back in a little bit. Back to you, Meredith.
Sean, thank you so much for that information. It is quite sobering to hear that, to be honest with you, but it's very important to understand this, and your sugar packet visual really brought that home. So thank you for that. We are compiling some questions. We see some things coming through. We are compiling questions, and we'll answer those in the Q&A section. Now I would like to turn this over to our second presenter, Dr. Furline. Okay, so Dr. Furline graduated from the MD PhD program at the University of Florida in 2008, the psychiatry residency program at the University of Texas Southwestern Medical Center in 2012, and addiction psychiatry fellowship at Yale University in 2013. He is currently an associate professor and the director of psychiatric emergency room at the VA Connecticut. Dr. Furline has a strong interest in medical student and resident education, particularly surrounding addiction psychiatry, and serves on multiple local and national committees in this role. In 2017, he was awarded the Irma Bland Award for Excellency in Psychiatry Resident Education through the APA. In 2018, he was awarded the Clerkship Faculty Teaching Award for Outstanding Medical Student Educator and Role Model. He is also passionate about emergency psychiatry and substance use disorders, and has presented his published his work surrounding opioid use disorder in the emergency room setting. In 2019, he was inducted into the American College of Psychiatrists, an organization that recognizes excellence in clinical practice, research, academic leadership, or teaching. Currently, Dr. Furline serves as Associate Professor of Psychology at Yale and Director of the Psychiatric Emergency Room in the VA Connecticut Healthcare System. Dr. Furline, thank you for being here. The floor is yours.
Okay, thanks, Meredith. Pleasure to be here. Shout out to Dallas. I didn't see anybody in the audience from Florida or Connecticut, my other two sort of homes, but shout out to Dallas, where I spent 4 years in psychiatry residency. Beautiful place to live. So I'm going to try to compress as much information as I can in approximately 15 minutes. This is designed to be a very basic overview of substance use disorders will hopefully leave you with an appreciation of those struggling with substance use disorders. And I'll specifically speak about opiates towards the end. And I like to start this with an analogy. So if you imagine holding your breath, or if you would like to, you can participate and you can hold your breath. So as you begin to hold your breath, it is hopefully not yet uncomfortable, but maybe a bit distracting. After about 20, 30 seconds, it does get a bit distracting and you start to think about it. After 45 seconds to a minute, it's going to be very distracting and you're going to be quite uncomfortable. And at some point, breathing will become the most important thing at this moment. It'll be more important than this lecture, than this webinar we're doing, than your role in Big Brothers Big Sisters, than your job, than your family. At some point, it'll be more important than anything, because if you don't take a breath of oxygen, you could die. Or if you think about it in terms of starving to death of food. If you were in a situation where right now you needed to find food to survive, suddenly this would be less important than it is now, because food would be more important than almost anything else, because without it, you will die. So now imagine you're in that situation and we say the only way you can obtain the oxygen or the food that you so desperately need to stay alive would be as if you give us $1,000, or you get up and you walk out on your job, or you steal the money from your family. You wouldn't want to do any of those things, but if that was the only way that you could obtain food or oxygen to continue to survive, you would do it. You'd feel bad about it, but you would do it. And then imagine that you finally obtain oxygen, or you finally obtain food again. You don't feel high, you don't feel intoxicated, you feel normal again, and now you can function. And imagine that at some point later today, that process will occur again, where you're going to be starved of food or oxygen, and you're going to need to figure out a way to obtain it desperately, or you could die again. So throughout the periods of time where you're reasonably comfortable and breathing normally, you might be thinking about the fact that, well, at some point later today, I'm going to need it again, and you might be very distracted and overwhelmed with this. So if you take that and you now replace the food or the oxygen with drugs or alcohol, and what I want you to understand is that when someone, for reasons we'll talk about next, when someone becomes addicted to drugs or alcohol and their brain crosses a line to that addiction, the single most important thing to that brain is finding the next hit or use, finding the next drink, finding the next heroin or fentanyl or methamphetamine. That is the single most important thing to that brain. And when the person experiences what they're seeking so desperately, often it's not to feel high or intoxicated, it's just to feel normal again. So how does that happen? So we have a system in our brain called the reward system. And I don't know if you can see my mouse, but it is deep within the brain. It is the structures that are very primitive in our brain, the structures that have been around as we've evolved for thousands and thousands and thousands of generations. This reward system has remained. And if you think about lower level organisms like birds or squirrels, this is really what they do, is their behavior is driven by a reward system. What the reward system does is gives us a surge of dopamine, which is a pleasure molecule. It's what enables us to feel pleasure, feel good. It gives us a surge of dopamine when we engage in activities that enhance our chances of survival. So things like eating food, particularly high fat, high calorie foods, those are the best to keep us alive. When we engage in sexual activity, because it increases our chance of survival as an organism, as a family, as a species. So we need to procreate. When we find water, when we're around our offspring, that is also rewarding, right? Raising offspring can be very rewarding as well, and being around children. So the reward system's goal is to keep you alive long enough so you can procreate and keep your children alive so they can procreate. That's the point of the reward system evolutionarily. Now, in our society today, we have this much larger, more evolved part of the brain, which is all the squiggly part on the outside. That's called the cortex. And the cortex has evolved with us as we have become more complex organisms. We typically don't need to worry about finding food and surviving today. Instead, we worry about doing these types of things for work, or it might be taking your children to their soccer match tonight or paying your bills on time. These are all things that we worry about in our current society. And these are complex things that we have to navigate over time, not as simple as find food or die. These are more complex things: paying bills, managing a family, having a house, having a job, being on time. These are complex things. So the cortex has evolved to manage that. And in a healthy brain, we have a balance between the cortex, which is dictating typically all of your normal day-to-day behavior. For example, we're all here today doing this activity, not because we need to survive, but because there's some inherent benefit to us for doing this. We're balancing that with survival. And again, in our society currently, we don't usually have to worry so much about the survival. So we hand over the day-to-day decision-making to the cortex. And the cortex says, oh, go to this webinar today because it's going to be good for you. You're going to learn something. You're going to be, a better person for it. But if you were suddenly starving to death, as I mentioned earlier, the reward system is going to say, yeah, I understand that you, cortex, wants to sit through this webinar to learn and be a better person. But if we don't find food, we're going to die. So let's not worry about what you really want. Let's worry about what we really need. And we're going to find food instead. So that balance will tip the way of the reward system when needed. And ultimately, survival is more important than work. It's more important than your children. It's more important than anything else. If you do not survive, nothing else matters. And the reward system is very powerful for that reason, that when it needs to exert an influence, it will, and it will override your cortex, the rational part of the brain. It's going to override that and force you to do something you might not want to do if it perceives life depends on. Okay, so the reward system and the cortex, we have this system in our brain to keep us alive. Find food, find water, have sex, raise offspring. These are the very basics of life. But in today's complex society, we don't rely on that system so much. We rely far more on our cortex to solve more complex problems and make more complex decisions. Okay, so that's a very healthy balance for most people. If you introduce drugs of abuse, particularly things like methamphetamine or cocaine or heroin, these drugs activate that reward system, the system that's designed to keep us alive. It activates that system by causing a massive surge of dopamine in your brain, far more massive than food or sex. And you don't have to worry about this graph, which is a little complicated. What you can look at is the top left. Again, I don't know if you can see the mouse, but look at the top left. Okay, this is amphetamines. And this is dopamine release in the brain of animals when given amphetamine. And you can see this massive spike of dopamine when animals are given methamphetamine or cocaine, a big spike of dopamine release. So the reward system, which again is designed for survival, now has this artificial thing put into it, this drug that activates that system. This survival system is activated by the drug. So the survival system interprets the drug as something important for survival, because that's what the system is designed to do, keep you alive. And if this methamphetamine thing or this heroin thing activates me even more strongly than food, then this methamphetamine thing must be even more important than food, because why else would it activate me so powerfully? Your cortex, which is the healthy decision maker, feels pleasure. Just like if you eat a good meal that's unhealthy, your cortex still knows it tasted good, but may say, well, don't eat so much of it because it's not good for you. The cortex interprets methamphetamine or cocaine as feeling really good, but also knows it's really unhealthy. So again, in a healthy brain, the cortex will win that battle and say, let's not do any more drugs. But once the disease of addiction develops, the reward system begins to take over the voluntary control from the cortex and treats the drug or alcohol, whatever that substance is they're addicted to, as necessary for survival and willing to do whatever it takes to find the drug today. And that's when that disease develops. There's a change within the brain that causes that person to compulsively seek the drug at the expense of everything else. And if you think about someone addicted to alcohol, if you ask them, or drugs, if you ask them, what is more important to you? Alcohol, this bottle of vodka that you have on your table, or your children? Well, their cortex will say, well, of course, my children are more important than alcohol. And that's true. But yet, if they have the disease of addiction, the threat of losing their kids is not enough to get them to stop drinking. They will drink anyway, because it is so powerful of a drive that consequences don't matter. Just like if you ask someone, what's more important, you know, something else related to your survival or your children, you're always going to say your children, but you're going to turn to the thing that you need to stay alive, despite the fact that there may be a consequence. So what I want you to remember is that when the disease of addiction develops, the cunning and baffling nature of the disease will dictate the behavior of that person, will seek their substance at the expense of everything else in life that they care about. And this is not a choice, because people would not choose to destroy their marriage, to destroy their children's lives, to destroy their work that they worked 20 years in their career for. People would never choose to destroy those things volitionally if they could just simply stop drinking instead. The compulsive nature of the illness drives them to continue to drink, and that's a change that occurs within the brain, partly driven by this powerful reward system. Now, with opiates in particular, the way in which the opiate use disorder typically develops that we see in the medical world is it usually starts with pills. And that's why what Sean was saying is so dangerous, is that these counterfeit pills now that have fentanyl in them can kill you when you think you're taking something relatively safe, which is like a 30 milligram oxycodone. I know how that treats me, but instead it's actually a couple micrograms of fentanyl, which will kill me instead. Most of the time, pills are how these things start. Either a pill that you're prescribed, say you had an accident and you hurt yourself, or pills that you obtained from someone else. Again, all the more important reason to keep those medications out of the reach of everybody, or discard them the appropriate way when you no longer need them. So either way, the person would start with pills. People will realize these pills make them feel really good. A small percentage of the population can take a 30 milligram oxy or whatever other opiate might be by mouth, a pill, and they will say things like, for the first time in my life, I knew what love was, or I finally found happiness. And this powerful feeling that opiates give certain people is really dangerous. And that's what causes them, that initial reaction is what causes them to start seeking more and more opiates. Eventually, they begin to buy pills on the street because they can't obtain them from doctors anymore. Very expensive. In New England area, they're about $1 a milligram. So a 30 milligram oxy is about $30 per pill. So that's very expensive when you're using multiple pills per day. And very quickly, the life savings begins to go. So then people who get addicted to this continue to need it despite running out of money. So they often switch to something a lot cheaper, which would be heroin or fentanyl. These things are significant. They're not free, but they're significantly cheaper than the pills that people buy. And then people start to use heroin or fentanyl, but say, I'll never inject that because that's something I would never do, but I'll sniff it. And then eventually they inject it. And then they share needles. And there's lines in the sand that are drawn. And eventually people gradually step over those lines. And people go from an accident with an injury with a prescription to someone who's injecting fentanyl. And that process can be relatively quick, a few months even for people. And that's a typical way. That's not the only way people can get addicted to opiates, but it is a typical progression of how people can get addicted to opiates. And it's not everybody who gets a prescription that gets addicted. It's a small percentage. But people who get prescriptions, especially large doses and big prescriptions, put themselves at risk ongoing because they're continuing to take it. Now, it's not all bad news. We have 3 medications that are essentially life-saving for many people, and they're very effective. And the point of this slide is just for you to understand that medications are very effective, specifically for opiate use disorder, and to see the names of the medications at least once. So oh yeah, I remember that methadone thing or that buprenorphine thing. I remember the doc saying that was really helpful. If you know anybody with an opiate use disorder, we try to encourage them at however we need to be on one of these 3 medications for maintenance treatment because they are so helpful and so life-saving. So again, I'll wrap up here. Understand the basics about the disease process of addiction, how one gets addicted, and know that that is no longer a choice. It is a disease process, and know a little bit about opiate use disorder and that we have these really effective medications to help them. And I'll be around at the end if there's any questions. So I will turn it back over, I guess, to Meredith.
Thank you so much, Dr. Furline. I really appreciated how you took all that science information and broke it down for us so that it's very accessible and understand for those of us who might not be MD PhDs like you are, to understand what is going on and really understand how this works. So thank you for that. At this point, I'd like to turn this back over to Sean Ferns. He is going to share some resources with us, some resources so that you will have some ideas of where to go for more information.
Meredith, thank you very much. I can't stress enough the importance of following the science and what Dr. Furline is talking about in terms of how substance misuse can lead to, eventually into the issue with addiction. Obviously, when we talk about littles, we're talking about young people, and the message we need to send is that we don't want any substance misuse or substance use for individuals that are youth or young adults. That's just a way that the science says that if we can delay the initial onset of substance use until the brain reaches full maturity, the chances of addiction drop dramatically. So let's talk about some great resources that are available to you at no cost. You can scribble these down, or the Big Brothers Big Sisters can share these slides with you. Some great websites. First to you as a mentor in the program, GetSmartAboutDrugs.com. This is our website geared for parents and caregivers to give you information to be more knowledgeable about the major drug types, what they do to the brain and the body, risk factors and protective factors that help to prevent the issue from affecting the family. Some great videos and some great interactives. Top left corner of this slide. Top right side of the slide is the site we've developed for youth, for teens, justthinktwice.com. A lot of the same kinds of information to help educate kids so that they can make healthier decisions, but it's obviously presented in a way that's more appropriate for youth and talking, teen to teen, peer to peer. Bottom right-hand side of this slide is one of our newest websites, campusdrugprevention.gov. The reason that has a .gov web address is that this is a resource for universities and colleges to help try and bring the issue of prevention to the 18 to 25-year-old range. There are a lot of information available there, podcasts and other information. So, frankly, if you have a child that's in or headed to college, there might be some really helpful information on that website. And then the last website I'll mention this morning is operationprevention.com. This is our co-sponsorship, our partnership with the folks at the Discovery Channel, specifically Discovery Education, to build some free, no-cost, science-based, evidence-informed resources that teachers could use in the classroom, that homeschool parents can use at home. We've recently added material that is developed through the lens of Native American, Alaska Native populations so that it is culturally appropriate. There's material there in Spanish. It is a bit about the science of addiction. It's a bit about the science of opioids, but we've also added material on other drugs of misuse that's there. Our most recent addition to it, again, operationprevention.com, is that if you happen to be a business owner or an employee in a workplace where the employee assistance program is charged with providing drug education in the workplace, there are some specific and opioid related resources there for businesses to use to help prevent this from happening and also for offering support for treatment and recovery for those that do have the issue. Move on to an awareness campaign that we're doing specifically on the counterfeit pill issue. And I'll just draw your attention at the bottom of the screen to DEA.gov/1pill. This message we're sending is that one pill can kill and that you should not take a pill that's not been prescribed to you by a medical professional and filled by a professional pharmacist. That is where that line has to be drawn. Follow proper medical procedures. Let's talk about some publications. We have publications that DEA creates in partnership with other federal agencies across the government. You can get them in hard copy from us, and my contact information will be at the end of this presentation, but you can also download them right now on the website. If you go to getsmartaboutdrugs.com/publications, you can get any number of these. We have over on the left-hand side is kind of our flagship publication, Drugs of Abuse. And it's a resource guide for parents and caregivers and community leaders to be more knowledgeable about the major drugs of misuse that are out there. The little blue book there is Prescription for Disaster, How Teens Misuse Medication. Growing Up Drug-Free is our most recent update, and I happen to have a hard copy right here in front of me. This is actually co-produced between DEA and the U.S. Department of Education. Really, really great resource, and I think we'll probably be able to talk a little bit more about that in the Q&A. And then finally, we've got some fact cards on major drugs of concern, whether it be marijuana or cocaine or heroin or fentanyl. Again, our goal is to provide people with information to be more knowledgeable so that when you have to have the conversation, or if a little brings up the conversation with you, that you're able to talk about it. What else is a resource? The DEA field offices. We have 226 offices around the United States. Invite you to please feel free to reach out to those local offices. We've had agents go and give speaking engagements at local community groups. It happens all the time. We actually had agents in Knoxville, Tennessee, recently meet with a big and his little. And all you have to do is go to dea.gov/divisions. And you can navigate through, frankly, I think it's a Google map that allows you to find where the local office is and contact information to get in touch with us. We are a resource, but we also know that we aren't the entire way to solve the issue. And so there's opportunities for us to connect you with other organizations in your community. Another resource, and it gets back to prescription misuse, is Take Back. For the last decade, DEA has sponsored twice a year in October and April the National Prescription Drug Take Back Days. We don't have the specific date for the one in the spring yet. It will be in April. But the bottom line message here is that folks need to absolutely control their medications when they're in their possession. And then they need to dispose of them properly when they're done, whether they've finished the prescription or not. It needs to be disposed properly. And if you go to deatakeback.com, you can actually put in your zip code, and any day of the year, it will point you to nearby authorized, legitimate take-back locations, whether it's a police department or a pharmacy or a doctor's office. There are thousands and thousands and thousands of locations, more and more coming online every week, where people can go and get rid of unneeded, unwanted, or expired medication so that it doesn't get diverted and misused, unfortunately. Another resource, if you happen to be in the Washington, D.C. area, this is a physical venue, the DEA Museum. We are located directly across the street from the Pentagon in Arlington, Virginia. But even if you're not planning a trip to Washington, D.C., I invite you to go to the museum's website, deamuseum.org. We have virtual exhibits, interactives, downloadable lectures and programs on any number of variety of topics. Basically, it's the history of the drug use in America. And obviously, those who do not learn from history are doomed to repeat it. And so there are some incredibly important lessons to be learned, not just from our history, but also from the science that's presented through the museum. A non-prevention related resource, but one that we absolutely want you to keep handy, is that if you do encounter an individual in your life that does need treatment services, our colleagues over at SAMHSA, the Substance Abuse Mental Health Services Administration, they maintain a very, very helpful locator for legitimate drug treatment facilities. And it's either online at findtreatment.gov or by calling that 800 number, 800-662-HELP 4357. And it's not just important to get folks to help, but then also to support them in their recovery, which is lifelong. At the end of the day, our bottom line is we're working to make communities safer and healthier. And we're going to continue to go after drug trafficking organizations that are bringing these poisons into our community. But we want to thank each and every one of you in the Big Brothers, Big Sisters as you work to mentor youth to help them grow up safe, healthy, and most importantly, drug-free. My contact information is here. Please feel free to reach out. If we can't help you at the headquarters level in Washington, D.C., then we certainly look forward to connecting you to our local DEA office in your community. And with Meredith, I will leave it there and turn it back over to you.
Okay, wonderful, Sean. Thank you for sharing those resources. It's really nice to know some trusted resources where we can go and get the most accurate, up-to-date information. So thank you for that. And as you were following along, you may have noticed that in the chat, we were putting the links to some of those resources as Sean was going through them. So if you didn't get a chance to screenshot those or take a photo or something, they are in the chat, so you can check there. And this presentation will be made available to you through Big Brothers Big Sisters sometime later after this is done. So wanted to let you know that. So thank you, Sean, for those resources. Okay, so we've reached the point in our time together where we're going to be doing some more interactive types of things. I would like to ask you a question and then have you, this is a very simple poll, okay? So we have one question, and the question is this, and when you answer the poll, you're just gonna put your answer right in the chat. So here's the question, okay? Assuming that the parents or guardians of your little has given you permission to talk about substance abuse, how hard is it to have these conversations with your littles? Okay, now here's the scale, 1 to 5. 1 is, it is really hard and I don't know how to do it. And 5 is easy peasy, super, no problems whatsoever. So again, put your answer in the chat. The question again is, assuming parents or guardians have given you permission to talk about substance abuse, how hard is it to have these conversations with your littles? 1 is very hard, 5 is super simple. So thank you for your responses. I see a lot of things coming in, answers coming in. 4, 4.5, 3, 5, 4, 4, 3, 3, 3, 3.5, depending on the age of the child. 3, 3, interesting. 3. Okay, so this is very great. So you're finding it at least somewhat easy to have these conversations. So 4. So what I'd like to ask is, if these conversations are somewhat easy to have, I would love for you to share, like, what is making that easy for you? Like, how are you starting these conversations with your littles? If you have a thought on that, if you could share that in the chat, we'd love to just hear like a few sentences from you. What makes it easy for you to have these conversations with your littles? Is it perhaps the amount of time that you spend together? Have you already built up trust with them? Yeah, okay, Olivia says already having a relationship and equity with the child. Yes, I'm sure that goes a long way. This is not the first conversation you probably want to open with. Having a relationship makes it easier, Rebecca says. My little is about to head off to college, so it's a discussion we will have to have. Okay, good. Most of my conversations have been started based on questions from them. For example, seeing a billboard about Narcan or prevention. Awesome. So you see things out there in the community and it just opens up a conversation. Beautiful. It's easy for me because of the trust. You all are amazing at building this trust. Easy to introduce the topic because marijuana use was what prompted mom to get him into the program. Okay, so moving from real life experiences then and just being able to be there and hold that space for them and have that conversation. Amazing. You all are really, really great at what you do, and thank you for all your work. Someone else, Wendy says, my own comfort with the subject. Our country in New Mexico, our county in New Mexico has one of the highest opiate addiction overdose rates in the nation. So the littles are receiving education from multiple areas. So they're already in the conversation. So you're just springboarding from that. So that is beautiful. Thank you for sharing all those things. It just helps us to understand, where you are and what other resources might be helpful to you. So thank you for all that. I really appreciate that. Sean, I'd like to turn this to you for a comment.
Yeah, if I can, Meredith, that was fascinating to watch, and I really appreciate you guys asking, the ease or difficulty of having the conversation. For those that didn't share, or for those that didn't rank it as super, super easy, let me just offer a suggestion. Our new Growing Up Drug-Free publication, DEA's had this with the U.S. Department of Ed for many, many years, but this is a 2021 update. We just updated it and relaunched it, I think, like 3 weeks ago. But there is actually an entire chapter it's not a huge document. It's only about 50 pages. But there's actually a chapter, how do I talk to my child about drugs? And guys, the tips actually start in the preschool age. So there's preschool tips, elementary school tips, middle school, high school, and then the college years. And there's conversation starters. How do I talk about alcohol? The do's and don'ts about conversation. We get asked a lot, what's the age where we can start to have conversations with youth? And the bottom line answer is it's never too early. It's just how sophisticated the conversation can get. The younger the child, it's about what's a good decision, what's a bad decision, what does it mean to be healthy, what is it about taking medication the right way, those basic fundamentals, rather than as they get into high school and college, it can be about dopamine receptors and addiction science and what Dr. Furline was so appropriately talking about earlier. But again, great resource. Please take advantage of it. I guess, Meredith, if I have one point, it's just please try and find ways to bring it up and talk about it, because to not talk about it, whether it's through that prevention message for youth or getting folks help if they need it, that doesn't do anybody any good. Thanks.
Absolutely. Thank you for sharing that. And the link to that Growing Up Drug Free was just put in this chat again. So if you're looking for that link, it's just right there in the chat. So you can go grab that there. And Sean, you actually read my mind, because we're going to move into the Q&A section where you can ask your questions. So if you had questions that came up, I have been compiling some questions. So as things come up, add your question in here. We'll do our best to get to everything. But my first question, Sean, was exactly that. We had a couple questions come in before, and it was, how do I start the conversation? So you've answered that beautifully. Thank you so much. The second question, someone said, what's the best way to respond if my little asks why it's okay for adults to use substances like alcohol, but it's not okay for kids? That's a great question. Sean, do you have an answer to that?
Well, I'm going to say, guys, it's all about the science. Science shows us that the youth brain is still developing. And this is a joke at the expense of the men attending, not at the women, but boys' brains develop slower than girls. And so that's why there's a range of between 21 and 25 years old. Girls' brains are more mature by 21 and boys' brains by 25. And that by delaying onset of substance use and substance misuse until the brain reaches maturity, you dramatically decrease the risk of addiction. And so that's why this message of no substance misuse for youth is so critically important. We can have debates and discussions all day about marijuana that has been made legal for medication and for recreation in certain states, but that never applies to our littles. That never applies to youth, because again, it's about trying to prevent substances from getting to the brain before that brain is mature enough to be able to handle it. Because by delaying it, you're delaying the onset of the potential for addiction. And perhaps Dr. Furline has to add to that.
Yeah, no, I mean, it's very clear that the adolescent or non-fully developed brain is far more susceptible to developing a substance use disorder given the same exposure to a substance than the adult brain. And if you're 40 or 50 years old and have not already experienced a substance use disorder, your risk is very low, even with exposure. That's not to say you wouldn't get addicted, but it's lower. If you introduce two brains, one who's 14 years old and one who's 50 years old, the same drugs, the 14-year-old is orders of magnitude more likely to become addicted to that substance.
Wonderful. Thank you. Thank you. Another question that came in, and Sean, this came in during your presentation, talking about fentanyl being added into the pills. Why are they adding it in the pills? Yeah,
really good question. And I'm asked this quite frequently because I think everybody assumes, well, are they actually trying to kill their customer base? The answer is no, they are not actually trying to kill their customers. The reason that fentanyl has become an additive into the drug supply is, quite frankly, the economics of attempting to get people addicted to their product. Fentanyl is 100 times more powerful than morphine, the morphine drip that you get at a hospital. Fentanyl is 100 times worse than morphine. It's 50 times more powerful than heroin. The risk is the production is so shoddy. If you look at it as these black market chemists are producing these drugs in these jungle laboratories or these backcountry laboratories, and they're putting the chemical ingredients in a blender or a cement mixer, and they're tumbling it around a little bit, and then that powder is put into a pill press that's been clandestinely acquired. The mix is not uniform. And so some pills are going to turn out to have no fentanyl in them at all. And they may not even have any psychoactive ingredients whatsoever. Other pills are going to come out of that process overloaded with fentanyl well beyond even the 2 milligrams that is a potential fatal overdose. So the goal would have been to try and get fentanyl, a little bit of fentanyl into each pill so that they can actually build a client base by getting people addicted to these substances. But then ultimately through that shoddy production and through what Dr. Furline described earlier, which is that progression of the brain becoming more attuned to these substances and seeking out a higher high, then that behavior, which is no fault of the individual, leads them to seeking more and more of the product, which ultimately can lead to what we have so tragically experienced, which is over 100,000 Americans lost to overdose death.
Just to add one quick thing, we're seeing fentanyl now showing up in stimulants, particularly cocaine. In the Northeast, we see more cocaine than methamphetamine, but we're seeing cocaine and fentanyl. And when you ask the patient, did you know that you have fentanyl in your urine? The patient often says, oh, I had no idea I had fentanyl in my urine. I thought I was using cocaine. And then the question is, well, why would a dealer or a manufacturer be putting a potentially lethal substance in an unrelated substance, right? There is no tolerance. If you've never used fentanyl and you only use cocaine, that's a different type of drug. And then if fentanyl's in there, you could die. So again, like Sean's saying, does the dealer or the supplier want to kill the customer? No, they're willing to take the risk, but the end result being a better experience for the customer. There's a concept called speedballing, where people who use drugs enjoy the combination of a stimulant, cocaine, and what we call more of a sedating thing like an opiate. That combination is actually sought after. So if a dealer puts a little bit of fentanyl, which is very inexpensive, puts a little bit of fentanyl in the cocaine at the risk of killing the customer, but giving the customer an enhanced experience, the customer may not know why. They just know, oh, whatever batch this is, this feels really good. I like this. I'm going to buy from this guy again, or this one again. They're more likely to return. So again, the benefit to the dealer is this is going to be something that will appeal to many people because it's a great product at the risk that some may die. And the economics would say it's worth that risk.
We could, I'm sure, talk about this forever. I mean, we have these two experts on the line. We have one more question. We've got 1 minute. And Sean, this is for you. Let me find it here. Wendy says, could you talk about the barriers to getting fentanyl off the market? It's been confounding us for so long now, and it's getting worse. So again, we have like 1 minute.
Okay, Cliff Notes answer. It's about global economics. The fentanyl, the illicitly produced fentanyl, is precursor chemicals coming from China. So we have to convince China to regulate those precursor chemicals and to regulate the trade of those precursor chemicals being bought and or smuggled to Mexico and other South American and Central American countries, produced down there. So then we have the issue of being down there, trying to work with our foreign counterparts in those countries to stop the production and the supply. And then you've got the transshipment into the United States through drug trafficking organizations and gangs. So there's multiple places along the chain where supply reduction has to affect its work. Frankly, if we eliminate and reduce the demand in this country, we are the world's superpower when it comes to drug consumption. But if the demand for the products in this country were lower, then that ultimately, if we're preventing it from being a problem in the first place, that ultimately is going to have the best approach for our kids and their kids.
Thank you. Thank you for that. And thank you to all the mentors who showed up today for this opioid awareness seminar. I want to turn this back over to Julie for a couple final comments.
Thank you so much, Meredith. And thank you to Sean, to Brian. I just want to say this presentation and this training would not be possible if not for a grant awarded by the Office of Juvenile Justice and Prevention, Delinquency Prevention. I do want to share our information as well. If your question was not answered, or if you have other questions for the expert panelists, you can reach out to us You can reach out to your match support specialist, or you can reach out to the expert panelists, the information that they provided as well. Thank you all for attending the training today. We really appreciate your time, your feedback. Thank you so much, and have a great rest of your afternoon.